Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of galactosemia for general pediatricians. Galactosemia is a treatable inborn error of metabolism where early recognition can be life-saving. Across this lecture, we will work through 14 clinical cases covering recognition of the neonatal presentation, infectious complications, the underlying pathophysiology, newborn screening, confirmatory diagnosis, differential diagnosis, dietary management, long-term monitoring, endocrine and bone complications, acute crisis management, the natural history of cataracts, and the Duarte variant. Let us begin. Case 1. A 6-day-old neonate presents with progressive jaundice, poor feeding, vomiting, and lethargy since day 3 of life. He is exclusively breastfed. Urine-reducing substances by CliniTest are positive, but the urine glucose dipstick is negative. The liver is palpable 3 centimeters below the costal margin. What is the most likely diagnosis? Option A, classic galactosemia. Option B, neonatal hepatitis B infection. Option C, biliary atresia. Option D, physiological jaundice. The correct answer is option A, classic galactosemia. The key clue is the dissociation between positive urine-reducing substances and a negative glucose dipstick. CliniTest detects any reducing sugar, including galactose, while the dipstick is specific for glucose only. A positive CliniTest with a negative dipstick means the reducing substance is not glucose, and in the jaundiced neonate, that points strongly to galactose. Add conjugated jaundice with direct hyperbilirubinemia, hepatomegaly, elevated transaminases, and coagulopathy. The classic triad is a jaundiced breastfed neonate, hepatomegaly, and positive urine-reducing substances, which is galactosemia until proven otherwise. Case 2. A 7-day-old breastfed neonate with galactosemia presents in septic shock. Blood cultures are pending. Which organism is most classically associated with overwhelming sepsis in untreated galactosemia? Option A, Group B Streptococcus. Option B, Staphylococcus aureus. Option C, Escherichia coli. Option D, Listeria monocytogenes. The correct answer is option C, Escherichia coli. In untreated galactosemia, accumulated galactose-1-phosphate impairs neutrophil bactericidal function. This defect in innate immunity leaves the neonate unable to clear gram-negative bacteria effectively. The result is overwhelming Escherichia coli sepsis, which can be fatal before the underlying diagnosis is even established. This is a critical teaching point. Any jaundiced neonate presenting with Escherichia coli sepsis should be considered to have galactosemia until proven otherwise, and empiric broad-spectrum antibiotics must be started without delay. Case 3. A 10-day-old neonate presents with jaundice, hepatomegaly, and Escherichia coli sepsis after breastfeeding. Which metabolite primarily accumulates and causes acute organ toxicity in classic galactosemia? Option A, galactitol. Option B, uridine diphosphate galactose. Option C, glucose 1-phosphate. Option D, galactose 1-phosphate. The correct answer is option D, galactose 1-phosphate. In the Leloy pathway, dietary lactose is split into glucose and galactose. Galactose is converted by galactokinase into galactose 1-phosphate. The next enzyme, galactose 1-phosphate uridyltransferase, is absent or deficient in classic galactosemia, so this step is blocked. Galactose 1-phosphate then accumulates and causes direct toxicity to the liver, brain, kidney, and lens. Importantly, even when dietary intake stops, the body continues to produce galactose internally, so accumulation persists. The genotype Q18ER in the homozygous state produces the most severe accumulation phenotype. Case 4. A 5-day-old neonate has a positive newborn screen for elevated total galactose. Which additional analyte is measured alongside total galactose to increase sensitivity and detect the Duarte variant? Option A, galactose 1-phosphate uridyltransferase enzyme activity. Option B, urine galactitol level. Option C, serum bilirubin. Option D, red blood cell galactose 1-phosphate. The correct answer is option A, galactose 1-phosphate uridyltransferase enzyme activity. Total galactose rises early, but normalizes rapidly once lactose is removed from the diet, so it can miss the diagnosis if the diet has already changed. Galactose 1-phosphate uridyltransferase enzyme activity, by contrast, remains reduced regardless of dietary change, which makes it the more reliable confirmatory marker. It reflects the intrinsic enzyme deficiency and stays low even after lactose elimination. Combining total galactose measurement with enzyme activity maximizes sensitivity across classic, Duarte, and other variant genotypes. Once lactose is stopped, enzyme activity, not galactose level, is the dependable marker. Case 5. A 6-day-old neonate with jaundice, hepatomegaly, and a positive newborn screen for galactosemia is referred for confirmatory testing. Which combination of tests best confirms the diagnosis and guides long-term management? Option A, urine-reducing substances and liver biopsy. Option B, total serum galactose and abdominal ultrasound. Option C, erythrocyte galactose-1-phosphate uridyltransferase enzyme activity and gene mutation analysis. Option D, red blood cell galactose-1-phosphate levels and urine galactitol only. The correct answer is option C, erythrocyte galactose-1-phosphate uridyltransferase enzyme activity combined with gene mutation analysis. The erythrocyte enzyme assay is the gold standard confirmatory test, a quantitative measurement of enzyme activity in red blood cells. Gene mutation analysis identifies the specific genotype and helps guide prognosis. Common mutations include Q188R, the most severe and seen in European ancestry, S135L, milder and seen in African ancestry, and K285N, of intermediate severity. Red blood cell galactose-1-phosphate levels confirm galactose exposure and monitor dietary compliance, while urine galactitol stays elevated even on a strict diet and is a reliable biomarker. Enzyme activity remains dependable even after dietary change, whereas galactose levels normalize quickly with lactose restriction. Case 6. A 3-month-old boy presents with bilateral white pupillary reflexes. There is no jaundice, no hepatomegaly, and no feeding difficulties. Liver enzymes and bilirubin are normal. The newborn screen was borderline. Which type of galactosemia most likely explains this isolated finding? Option A, classic galactosemia, galactose-1-phosphate uridyltransferase deficiency. Option B, galactose epimerase deficiency, severe form. Option C, Duarte variant galactosemia. Option D, galactokinase deficiency. The correct answer is option D, galactokinase deficiency, also called type 2 galactosemia. Galactokinase deficiency causes isolated cataracts without systemic disease. Comparing the two main types, in type 1, the classic form, the deficient enzyme is galactose-1-phosphate uridyltransferase, and patients have cataracts, liver failure, sepsis risk, and systemic crisis, with galactose-1-phosphate as the toxic metabolite. In type 2, galactokinase deficiency, the only feature is cataracts. There is no liver failure, no sepsis risk, and no systemic crisis, and the toxic metabolite is galactitol. Because galactitol accumulation in the lens drives the cataracts, dietary galactose restriction alone prevents progression. Case 7. A 6-day-old neonate presents with jaundice, hepatomegaly, and Escherichia coli sepsis. Newborn screening flags elevated total galactose, and classic galactosemia is confirmed. What is the most critical immediate nutritional intervention? Option A, discontinue all breast milk and lactose-containing formula immediately and switch to a soy-based or casein hydrolysate formula. Option B, continue breastfeeding but supplement with lactase enzyme drops. Option C, switch to a low-lactose cow's milk-based formula. Option D, initiate total parenteral nutrition and avoid all enteral feeds for 2 weeks. The correct answer is option A. The single most critical intervention is to stop all lactose and galactose sources immediately because this step is life-saving. This means stopping breast milk, any cow's milk-based formula, and any lactose-containing product at once. Safe alternatives are soy-based formula or casein hydrolysate formula, which are lactose-free and galactose-free. Continuing breastfeeding with lactase drops is wrong because lactase still releases galactose. A low-lactose cow's milk formula still contains galactose. Total parenteral nutrition is unnecessary when a safe enteral formula exists. One caution, diet alone does not prevent all long-term complications because endogenous galactose production continues, so ongoing monitoring remains essential. Case 8. A 7-year-old girl with classic galactosemia, genotype Q188R homozygous, has been on a strict lactose-free diet since day 5 of life. Liver function is normal, and she attends regular school. Which annual evaluation is most critical for her ongoing management? Option A, ophthalmology cataract check only. Option B, liver biopsy and hepatic panel. Option C, developmental, speech, and endocrine evaluation. Option D, renal function tests, and urinalysis. The correct answer is option C, developmental, speech, and endocrine evaluation. Even with strict dietary treatment from birth, children with classic galactosemia remain at risk for long-term complications. Apraxia of speech is the most characteristic long-term complication, and it occurs despite a strict galactose-free diet. Cognitive and language delays are also common, so an annual speech language and developmental assessment is required. On the endocrine side, 80 to 90% of females also develop primary ovarian insufficiency. The key concept is that diet prevents the acute crisis, but it does not prevent all of the long-term sequelae. Case 9. A 16-year-old female with classic galactosemia on a strict galactose-free diet since birth presents with primary amenorrhea and absent breast development. Laboratory testing shows markedly elevated follicle-stimulating hormone and luteinizing hormone with low estradiol. What is the most likely endocrine complication responsible for her presentation? Option A, hypothyroidism due to iodine deficiency. Option B, growth hormone deficiency. Option C, congenital adrenal hyperplasia. Option D, primary ovarian insufficiency. The correct answer is option D, primary ovarian insufficiency. This is the classic endocrine complication of galactosemia in females, affecting 80 to 90% of them. Galactose toxicity causes follicular depletion that begins in utero and continues after birth through accelerated follicular atresia. Because the ovaries fail, estradiol is low while the pituitary drives follicle-stimulating hormone and luteinizing hormone upward. This pattern of low estradiol with high gonadotropins is called hypergonadotropic hypogonadism. Clinically, it presents as primary amenorrhea or premature menopause, and hormone replacement therapy is indicated to support pubertal development and bone health. Case 10. A 7-day-old neonate with galactosemia presents in metabolic crisis with jaundice, hepatomegaly, an international normalized ratio greater than 4, and a blood glucose of 28 milligrams per deciliter. What is the most appropriate immediate management? Option A, stop lactose, give intravenous dextrose, fresh frozen plasma, vitamin K, and broad-spectrum antibiotics. Option B, exchange transfusion and phototherapy. Option C, oral galactose-restricted formula only with outpatient monitoring. Option D, liver biopsy and enzyme assay before any intervention. The correct answer is option A. This neonate is in an acute galactosemia crisis and needs intensive supportive care without delay. Intravenous dextrose corrects the dangerously low blood glucose. Give it as a continuous infusion and monitor glucose closely. Fresh frozen plasma and vitamin K correct the coagulopathy caused by hepatic synthetic failure, reflected by the international normalized ratio above 4. Broad-spectrum empiric antibiotics are essential because of the high risk of Escherichia coli sepsis, and all lactose must be stopped immediately, meaning cessation of breast milk and standard formula. Early intervention prevents neonatal death, so treatment must begin before confirmatory results return. Case 11. A 10-day-old neonate is diagnosed with classic galactosemia, and bilateral cataracts are found on slit lamp examination. The parents ask the pediatrician, what is the most likely natural history of these cataracts if the infant is started on a strict galactose-free diet immediately? Option A, they will progress to blindness regardless of diet. Option B, they may regress or fully resolve with early dietary elimination. Option C, they are permanent and require surgical removal. Option D, they only affect one eye and are not clinically significant. The correct answer is option B. Oil droplet cataracts can regress and may fully resolve when galactitol elimination begins in the first days of life. The mechanism is that galactitol accumulates in the lens through the action of aldose reductase, drawing in water and causing osmotic damage that produces the oil droplet opacity. When dietary elimination begins early, galactitol production halts and lens transparency can recover. If diagnosis is late, however, the cataracts become fixed and irreversible, which is why early newborn screening is so critical. Remember that cataracts are the only complication of galactokinase deficiency, type 2, and in that setting, they are also reversible with early diet. Case 12. A 7-year-old child with classic galactosemia, genotype Q188R homozygous, has been on a strict galactose-free diet since day 5 of life. Despite full dietary compliance confirmed by low red blood cell galactose-1 phosphate levels, she develops speech apraxia and cognitive difficulties. What is the most likely explanation for her neurodevelopmental complications? Option A, accidental dietary galactose exposure through hidden food sources. Option B, inadequate formula substitution in early infancy. Option C, endogenous galactose production from normal cellular metabolism. Option D, concurrent mitochondrial dysfunction unrelated to galactosemia. The correct answer is option C, endogenous galactose production from normal cellular metabolism. This is known as the dietary treatment paradox. Minimal turnover of glycoproteins and glycolipids continuously produces galactose inside the body, completely independent of dietary intake. So even with zero galactose in the diet, the body keeps making its own. Because the galactose-1 phosphate uridyl transferase enzyme is still deficient, this internally produced galactose still leads to ongoing galactose-1 phosphate accumulation and chronic low-level subclinical toxicity. The brain and ovaries are the most vulnerable organs. This explains why neurodevelopmental complications and ovarian insufficiency persist despite a strict and well-followed diet. Case 13. A 3-week-old infant identified on newborn screening has a D2/G compound heterozygous genotype. Galactose-1 phosphate uridyl transferase activity is 30% of normal. The infant is feeding well with no clinical symptoms. What is the currently recommended management approach? Option A, immediate switch to lactose-free soy formula and strict lifelong galactose restriction. Option B, perform a confirmatory liver biopsy before deciding on dietary management. Option C, monitor closely with repeat enzyme levels every 3 months and restrict diet only if levels rise. Option D, no dietary restriction required. Reassure the family and continue normal breastfeeding or standard formula. The correct answer is option D. For Duarte variant galactosemia, the D2/G genotype, routine dietary restriction is not recommended. This reflects the American College of Medical Genetics 2023 evidence-based guidance. In Duarte galactosemia, enzyme activity is 25 to 50% of normal, which is generally enough to keep the child asymptomatic. Comparing it with the classic form, classic galactosemia has enzyme activity that is absent or below 1%, severely elevated galactose-1 phosphate, and a real risk of neonatal crisis, liver failure, and sepsis, so a strict lifelong galactose-free diet is required. Duarte galactosemia has only mildly elevated galactose-1 phosphate, is typically asymptomatic, and has outcomes comparable to unaffected children, so no routine restriction is needed. Case 14. A 14-year-old girl with classic galactosemia on a strict lactose-free diet since birth has a bone density scan showing low bone mineral density for her age. She has primary amenorrhea and elevated follicle-stimulating hormone. Which combination best explains her reduced bone density? Option A, vitamin D deficiency only. Option B, estrogen deficiency from primary ovarian insufficiency plus calcium insufficiency from a dairy-free diet. Option C, excess galactitol deposition in bone. Option D, corticosteroid use and immobility. The correct answer is option B. Her low bone density is best explained by 2 factors acting together. First, estrogen deficiency from primary ovarian insufficiency. Because primary ovarian insufficiency affects 80 to 90% of females with galactosemia, she has chronic estrogen deficiency, and estrogen is essential for bone accrual, so its absence leads to accelerated bone loss. Second, her dairy-free diet reduces calcium and vitamin D intake, which impairs proper bone mineralization. Management combines hormone replacement therapy for the ovarian insufficiency with calcium and vitamin D supplementation, plus bone density surveillance. A bone density scan is recommended in adolescent and adult females with galactosemia, especially those with primary ovarian insufficiency. Before we close, I want to invite you to join our community on Patreon, Pediatric Case Review. The community brings all of our videos together in one place, organized neatly by system, so you can find exactly what you need without searching around. Every presentation used in the videos is also available as images, so you can read through them and practice all the questions at your own pace. It is a simple way to support the channel and to study more effectively. If you would like details on how to subscribe, just leave a comment below this post, and we will message you directly. Let us bring it all together with 6 critical clinical principles. 1. Recognize the neonatal triad. Jaundice, hepatomegaly, and Escherichia coli sepsis in the first 2 weeks of life mean galactosemia until proven otherwise. 2. Stop lactose immediately. Remove breast milk and standard formula at once and switch to soy or casein hydrolysate formula. 3. Escherichia coli sepsis is the killer. Impaired neutrophil function leads to gram-negative sepsis, so start empiric broad-spectrum antibiotics in every suspected case. 4. The gold standard is galactose-1 phosphate uridyl transferase activity combined with gene mutation analysis. 5. Diet does not prevent everything because endogenous galactose production causes ongoing toxicity. 6. Females need endocrine care with monitoring and hormone replacement for primary ovarian insufficiency. Thank you for joining this pediatric case review lecture on galactosemia. If you found this helpful, please follow the channel for more case-based presentations designed for general pediatricians. If you have any questions about today's cases, leave them in the comments and we will be glad to respond. Remember, this content is intended for educational purposes only and does not replace individualized clinical judgment. We will see you in the next lecture.